All right. Hey, what is up, everybody? Today we're doing something really exciting. I am meeting with my good friend Josh Wageman here, and we are going to talk about his new book. Josh, tell us the name of your book, and maybe you can show us the cover too. Can you?
Yeah, so this actually just came in. This is the proof. That's why there's this obnoxious not for resale bar through it, just in case I got any crazy ideas. But yeah, so this is my book. It's called The Home Security System and the Lipid Neighborhood: Uncomplicating Cholesterol and Cardiovascular Disease. And hey, this could be you on February 18th. And hopefully it is, because my whole goal in writing this book is for you to laugh a little, learn a lot, and then make some better sense of finding the signal amidst the noise when it comes to cholesterol, when it comes to cardiovascular disease, and the various factors that contribute to that. So I'm very excited. I think you'll enjoy it. And that's part of the reason why we're hanging out here today.
Perfect. Well, we will get into the questions, but I wanted to make sure I introduced you properly. So let me read this off. So Josh is a clinical lipid specialist who formerly practiced in endocrinology prior to transitioning to a role as a medical science liaison. His PhD work focused on cholesterol disturbances in Alzheimer's disease, and although he also has a doctorate in physical therapy, he is best known for his role in teaching lipid physiology. And I can attest to that. He is an outstanding teacher. He serves as an adjunct professor at several medical programs and recently wrote the book here that we're going to talk about today, The Home Security System and the Lipid Neighborhood: Uncomplicating Cholesterol and Cardiovascular Disease, which releases on Amazon February 18th. And like he said, he is just here to help you. And I can attest to that. Josh is a great, great person. He is super smart, as is going to be very evident after our conversation today. But also, when you read his book, you will see he is very, very smart, but has this incredible ability to distill things down so that even dumb cardiologists like me can understand things. And so I'm really excited for my patients to get a hold of this and really anybody, because I know it can help them in the fight against the number one reason why people die. So we should all take this very seriously because statistically it's the thing that is most likely to get us. And here's how we can fight back about that. So Josh, why don't we start with you telling us a little bit about how you got into this crazy complex world of lipids and how it piqued your interest.
Yeah. So, and you're far too kind, and you're also very smart, and one of the true good guys when it comes to this whole lipid charade. No one cares how much you know until they know how much you care, and you truly care. You know what? You know a bunch of stuff too. So, your patients are very blessed to have you. So, for me, like you said, I mean, I have all these degrees, and it just basically that just means I like going to school and I like taking tests, and I'm a weird guy. But I was sitting there a few years back, like 6 years ago now, and I had a patient cancel. It was a dark January day, and I'm always reading stuff, and I kind of fancied myself as a biochemistry aficionado. And there was this obnoxiously condescendingly titled article, something like "Basics of Lipoproteins." I'm like, okay, whatever, cholesterol. How hard can this be? And so I sat down to read this article, and I barely understood any of it, and it made me mad. And so I wish I had some, humanitarian reason of, some uncle had elevated lipoprotein little a and had a premature event. And so I dedicated my life's work to helping people avoid the same fate. That's not how it was. It's just because I was annoyed because I didn't understand something. And so, anyway, I was like, well, since this stuff I think is kind of important and relevant to cardiovascular disease, I should probably understand it a little bit better. And so that's where I threw myself in, plunged in headlong into this beautiful, elegant world of lipids. And it's such a fun exploration. I know a lot of stuff about lipids, but I learn stuff every day. It's so humbling and beautiful. And hopefully, I can use what I've gleaned over the years to help you not have heart attacks, strokes, and dementia, whoever you may be. And it's such a privilege to do so. One of my goals is to walk with kings, but not lose the common touch. I want to have a truly regal understanding of physiology, but I want to be able to disseminate it in a way that's relatable to both clinicians and non-clinicians. Because if I am just talking over here with crazy ANGPTL3, PI3 kinase, and all these different pathways and stuff, people are like, oh, okay, well, whatever, man. And then they never want to talk to you again. And so I want to convey these things in a way that you can vibe with me and have a better understanding of all these factors that can possibly contribute to having heart attacks, strokes, and dementia, which we don't want.
Absolutely. Well, let's get into it. you have, I think, a very unique framework to this. So let's talk about it. When you
Yeah,
approach this, how do you approach it? What is your framework for cardiovascular?
sure. So for everybody who doesn't want to have heart attacks, strokes, and dementia, I say, hey, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has four basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs. Drugs are bad. But then your lipid neighborhood is your cholesterol panel, because every ApoB containing particle, the majority of these being LDL particles, is potentially a criminal that can infiltrate your physiologic abode. And the LP little a particles, if you pick the wrong parents when it comes to that lipoprotein, those are the felons, because per particle, they're about 6.5 times as atherogenic as your run of the mill LDL particle. And so let's check your home security system. We have many ways of seeing what's going on with your parameters of glucose metabolism. We check your blood pressure. There's all these inflammatory markers and markers of endothelial function. And, if you're doing drugs, you probably consider stopping those. And then we have your cholesterol panel. And then we can maybe check in lipoprotein little a. And people who are a little more savvy might check in ApoB. But at the same time, people don't live on paper. And so one of my catchphrases is, got plaque? Get a CAC, which is the colonoscopy of the heart without the nasty pregame show. It's a coronary artery calcium score. And it shows if you have any calcified plaque in your coronaries, which is a late finding in the whole disease process. Now, there are other methods like CT coronary angio and carotid IMT with plaque assessment and iliofemoral ultrasound that it can detect plaque in other ways. And in certain contexts, those might be useful as well. But at the same time, if you identify any sort of plaque in your arteries, you've been broken into. You are living in a rough lipid neighborhood where there's been a break-in. So do you want to keep living in that same rough lipid neighborhood where there's been a break-in, or do you want to move to a nice, safe, gated community with fewer criminals? It seems reasonable. And so that's what we talk about. And there are multiple ways to do so. And so that kind of gives you the basic framework of how I can hopefully help people understand the purpose of these lipoproteins and also what can go wrong when the physiologic milieu has been perturbed.
Josh, I think that's just such a perfect encapsulation of your incredible abilities as a teacher, in that you went into some very complex things there, but at the same time, you were also able to break it down into, look, cardiovascular disease, very complex, but you want to keep your neighborhood good and you want your home security system good. And that's what's so cool about the book, is it walks you through, well, how do I keep my neighborhood good? What are the things I need to do? How do I keep my home security system to be the best it can be? And those two things are equally important, and you can get very deep in the woods on those. But as long as we just focus on these two broad things, which intuitively all make sense to us when we think about our house, we can take meaningful actions that are backed by science to lower our risk of the number one killer in the world.
Absolutely.
Good man. So one of the things, we first met on Twitter, and all it does is take someone about 5 minutes on Twitter to know that there's a lot of information out there, and it's hard to know what to believe. And so there's tons of misconceptions throughout Twitter or within the medical, conferences and debates. There's just so much misinformation out there. Can you talk about some of the misconceptions that you specifically address in your book?
Yeah, and there's so many things, and it's hard to know what to believe, and it becomes very tribal, and it's kind of who yells the loudest, tends to be the one who people believe most of the time. So that's why I try to root my philosophy and my rationales in the biochemistry that the good Lord hath ordained, and then the clinical data will often back that up, because you can't fight the genetics and the physiologic factors that contribute to these things once you have understanding of how it's supposed to work, but what could go wrong.
Mm-hmm.
And so one of the, there's some fallacies, there's all these fallacies, but I've precepted a lot of med students, PA students, NP students, everybody. And the common theme is what you're taught is LDL bad, HDL good, everybody take a statin. And then we're on to the next topic, and that's, you spend about 20 minutes in your didactic program on that, and then you go on your merry way. Yeah, there's a lot more to it than that. So first fallacy, LDL bad. Well, here's the thing. All of these ApoB containing lipoproteins, which would include your VLDL, IDL, LDL particles, the chylomicrons if you've just eaten, and the chylomicron remnants, LP little a has an ApoB, but that's a different discussion. We'll get to that in a little bit because its purpose is a little bit different. But the purpose of these ApoB containing particles is not to give you and I heart disease. They're mailmen, right? Most mailmen aren't bad dudes. You know, their job is to deliver the mail and then go home at the end of the day. The mail is triglycerides primarily, a few phospholipids, a few fat soluble vitamins, but primarily these particles are delivering triglycerides to your muscle cell and your fat cell, and then they go home to the liver at the end of the day. That's great. These mailmen aren't necessarily bad dudes, but if one of these mailmen goes rogue and runs his truck in your arterial wall, that's a bad mailman. And instead of delivering the triglyceride packages to the muscle cell or the fat cell, he's delivering plaquages to your arterial wall because it's not supposed to be there. And so I've even told this to my daughter, and she's like, plaquages. And so she's 7. So I'm like, hey, if she can get it, I think we can all vibe together. But here's the thing. You cannot have atherosclerosis without one of these mailmen going rogue. By definition, that is what starts the maladaptive immune response that contributes to plaque formation and then subsequent events. And so, okay, how it gets in there's another story, and that becomes a conversation of the home security system. Mm-hmm. But all these things do work well together. But it's not just a matter of saying, oh, LDL bad. Well, no. And then HDL good. Well, HDL is super complicated. Mm-hmm. And so HDL does a lot of good things. If we want to continue our metaphor of the home security system and the lipid neighborhood, the HDL particles could be fancied as like policemen, because they are capable of actually going in and taking a perpetrator who is laden with cholesterol from your arterial wall where it doesn't belong and running it back to the liver. And so they're capable of cholesterol efflux, which is what that's called. They're also capable of increasing glucose uptake into skeletal muscle. Not many people know that. And so that's a nice charitable donation of your time and resources to the community, because nobody ever said, boy, I wish I was worse at utilizing glucose. So HDL particles have a small role in that. And then what's really interesting is if you're having a real bad day and you have sepsis, which I don't recommend, if you can avoid having sepsis, that's preferable. But let's say that you've got a bunch of lipopolysaccharides around, or if it's a gram-positive bacterium, lipoteichoic acid. HDL particles can actually function as a sink for lipopolysaccharide or lipoteichoic acid, and then they can deliver that back to the liver, and then those pathogens can be excreted into the bile. And so that's really cool too. It's called reverse lipopolysaccharide transport. Holy smokes. So there's all these good things that HDL particles can do. But if we just look at a static measure of HDL cholesterol on your blood panel, you don't know what it's doing. You don't know if this is a good cop or a bad cop or whatever. You don't know. And a lot of times there's people with the really high HDL cholesterol levels. They actually have accelerated atherosclerosis because those HDL particles are dysfunctional. You don't know. Okay. And then, for the low HDL cholesterol, somebody out there is like, okay, well, low HDL cholesterol is associated with cardiovascular disease. Absolutely true. But the primary reason for that is because low HDL cholesterol really says this person is insulin resistant. Mm-hmm. So what happens is there are triglycerides that spike after you eat. And there's a protein called cholesterol ester transfer protein, CETP. And what this does is it takes the cholesterol from the HDL particle and it swaps it for the triglycerides on the VLDL or the LDL particle. And so it's kind of directing the swap meet here. And so the HDL particle is taking all the triglycerides and donating its cholesterol to the ApoB particle. Here's the thing. When there's way too many triglycerides around, the HDL particles get all fat and fluffy. That's not good. And so this is kind of like if you're, policeman who needs to pass his fitness test is getting super, super overweight. It's like, ugh, that's rough. We better do something about that guy. So big fat cop, no good. Well, what happens is your body tries to do a little fat loss procedure. There are various lipases that come on and try to trim the fat from this bloated HDL. Unfortunately, they overshoot it. And so then what you're left with is a gaunt, emaciated HDL particle who still can't be very functional and pass his fitness test. And so what happens is your body's like, that was terrible. And it takes it out of circulation. Over time, that occurs. And that's why we see low HDL cholesterol as a part of the metabolic syndrome. And so now there are exceptions. There are people with really low, very functional HDL cholesterol. But in general, if you're going to look at HDL cholesterol as anything, it's usually kind of like the hemoglobin A1C of postprandial triglyceride excursions. But you don't really know. So don't rely on HDL cholesterol to tell you one thing or another. It's generally indirectly telling you something about the overall metabolic milieu. So there's HDL. Does some good things. You don't know what it's doing. Don't rely on that to dictate your treatment decisions. And then everyone take a statin. Okay, statins do a lot of good things, right? And they have more data than any other lipid lowering drug as far as some of the good things they do. However, they're not a panacea. Okay. There are multiple studies of other lipid lowering therapies on top of statin that can help people get living in a safer lipid neighborhood while not compromising their home security system. The side effects of statins are dose dependent, meaning as you go up in the dose, you're more likely to run into side effects. And the most benefit you get from a statin, and this would be outside of the cath lab, outside of acute coronary syndrome, is going to be with your initial dosing. Each subsequent doubling, you maybe get 6% additional LDL-C reduction, and you increase the side effects quite a bit. And so I'm a big fan of being combophilic. People know that there's hydrophilic and lipophilic statins. Okay, that can be a nuanced discussion, but let's be combophilic, because whenever you're trying to move someone from a lipid neighborhood where you've gotten broken into to a safer gated community with fewer criminals, your body fights you. It reminds me of my grandpa. He was living in this rundown house. He couldn't even take care of his property anymore. There were literally rats there, which is not good. And he still wanted to stay there. He's fighting to stay in this place. It's like, man, let's just get you moved to a nicer place, man. That's what your body does when you try to move it using just one of our tools in our lipid lowering toolbox. Because when you decrease cholesterol synthesis with a statin, guess what your body does to cholesterol absorption? It increases it. Well, how do we address absorption? There's a drug called ezetimibe. And so you can hit two pathways at once, minimize the dose-dependent side effects of the statin, have people tolerate it better, and get them living in a safer neighborhood. Additionally, there's something called PCSK9, proprotein convertase subtilis kexin type 9. When you can rattle that off without sounding like you're going to vomit, then you know that you've kind of arrived at a special place in the world. But that is one of those things that is part of your checks and balances system, where if there's too much PCSK9 around, then your LDL receptors, which are how you clear these particles from your body, well, those get put out of commission. Statins actually increase PCSK9 levels. Well, that's not helpful. So how do we reduce those? Well, we have a class of medications called PCSK9 inhibitors that will address that problem. So the point here is we have multiple options, right? All of these things can work in synergy, and there's other options as well. And so there's so many options these days. The year is not 2004, where we have to kind of bend over backwards to try to get somebody on some dose of a statin, just because that's kind of all we had. But it's a new era. If you're going to have, a lipid neighborhood where there's been a break-in, hey, this is a good time as any to find that out before you have the big one and shift our paradigm from reactionary to one of prevention. We've got the tools to do so. It's just a matter of helping people better understand what's out there and the factors that can contribute to a break-in, but what we can do about it if there has been one.
Yeah, I think that makes it a really exciting time to practice, is that we've got both on the home security system front and on the lipid neighborhood front, we've got a lot of different agents that have been shown to improve those things so we can hit this massive problem, which is atherosclerotic cardiovascular disease, from multiple angles. And so, Josh's book will walk you through all the different types of medications and strategies that we could have to improve both the home security system and the lipid neighborhood to get the best chance of the best outcomes. And so you talked about HDL and LDL, and one of the things I would like you to address further is the felon in the neighborhood in your analogy, lipoprotein little a. It's a people don't know a lot about this, so please educate us.
Yeah. So lipoprotein little a. And so this is another instance of how humbling lipids are. We've known about lipoprotein little a since 1963, and we still don't know how it's cleared from your body. And we also don't really know exactly why it exists. It seems like it's associated with wound healing, a kind of hemorrhage maintenance or insurance when being attacked by a tiger was a more common way to die. What's interesting about lipoprotein little a is people who have keloids, they kind of have this raised scar. Those people tend to have higher lipoprotein little a. And then if you give somebody growth hormone, which is involved in tissue healing, if you're an athlete trying to cheat the system, that will actually increase lipoprotein(a). So that's interesting too. So, there are multiple reasons why we might think it's associated with wound healing. But at the same time, in our current context, most of the time it's just a bad guy, especially when it gets into your vascular endothelium. And so lipoprotein(a) is called prothrombotic, pro-inflammatory, and pro-atherosclerotic. And so it's called prothrombotic, and it was common to call it this because it's right next to the gene that codes for plasminogen on chromosome 6, is the gene that codes for Lp(a). So they're like, oh, okay, well, it's just preventing plasminogen to do its clot busting duties, because that's what plasminogen comes along. It comes in and dissolves clots, because you don't want a whole bunch of clots forming in your arteries. It's a little more complicated than that. There are various protease inhibitors like alpha-2 macroglobulin. There is something called histidine-rich glycoprotein on lipoprotein(a). There are other factors that contribute to inhibiting that normal dissolution of clots, but it's not a direct inhibition of plasminogen as once originally thought. However, it can lead to arterial clots, so that's no good. And additionally, the pro-inflammatory component of lipoprotein(a), once it gets in your artery where it doesn't belong, it tends to elicit a cascade of inflammatory cytokines. It has something called alpha-1 acid glycoprotein on it, which is in and of itself pro-inflammatory. There are multiple mechanisms that we're learning more about that make lipoprotein(a) nefarious. As far as the pro-atherosclerotic component, one of the more well-elucidated mechanisms of lipoprotein(a) is that it carries oxidized phospholipids. And so lipoprotein(a) has these little protein domains called kringles, because it looks like a Danish pastry. And, if you eat a lot of Danish pastries, you're probably going to be pretty sick. And lipoprotein(a) can also be pretty bad for your arterial wall too. So Danish pastries in excess, probably no good. But anyway, so on one of these kringle domains, the kringle 4 subsegment 10 domain, it carries oxidized phospholipids. Problem with that is when it carries oxidized phospholipids, it has really, really high affinity after it's been hydrolyzed to the cells of your aortic interstitium primarily. There's also a high affinity for cells of your vascular tree in general, but once it actually enters your arterial wall, it upregulates a cascade that is pro-osteoblastic, meaning bone. Bone in your vessels, bone in your aorta. That should strike you as a bad thing, and it is. And so that's why not only is lipoprotein(a) independently associated with myocardial infarctions, it's associated with aortic stenosis as well, calcific aortic valve stenosis. And so this, it can also be associated with heart failure and peripheral artery disease. And so there are many, many problems that lipoprotein(a) can end up, doing to your physiology. And it's one of those things too, where statins don't actually address the Lp(a). So on average, they actually increase lipoprotein(a) by 19% or so. Now, that's not a reason to not use a statin for other reasons, but if lipoprotein(a) is part of your problem, it's not going to address the lipoprotein(a). And so we don't currently have any specific drugs to reduce lipoprotein(a) and reduce cardiovascular events, though we hope to have those soon. But at the same time, there are ways to operate with nuance, and we won't get into that here today. But the recommendation is just check it, because you can't address and you can't treat what you don't know. And especially when there is hope on the horizon, one of the best things we can do as clinicians or people who talk to clinicians is give people hope, and I think that's a really, really powerful thing, and a powerful motivator to address all the things you can address, even if you were one of those people who picked the wrong parents. And I have a good friend who his one risk factor was lipoprotein(a). His 10-year risk calculator was 2.3%. And he had a coronary artery calcium score of 2,814. And he had so much extensive disease, he had to have a 5-vessel CABG, a coronary artery bypass graft. He's doing great now. But, if we just relied on our 10-year risk calculators and our standard metrics, he probably wouldn't be here. And so I think it's really important that you check lipoprotein(a) at least once in your lifetime. There's a couple situations where you might consider rechecking, and that would be after initiating a statin, perhaps, and in the menopausal transition is unfair for many reasons, but you can get a rise in lipoprotein(a) during that transition as well. But in general, just know it. If it's low, you never have to worry about it again, and if it's kind of intermediate or high, hey, there are certain things that we can we can do about it, and there's hope on the horizon. So interesting topic. We could go all day about lipoprotein little a, but it's a felon. So just know if you have some felons in your neighborhood, it's good to know.
Yeah, and one of the things I love about your book too is, these things can get pretty complicated, talking about the different mechanisms by which lipoprotein little a could be problematic or the different things HDL cholesterol does. But your book has some incredible pictures that really simplify these things so that even normal people can, like me, can try to figure out, okay, what does this actually mean? How can I make it make sense? And the illustrations do an incredible job in the book. So I'm a big fan of picture books, as a dumb cardiologist. So this is an incredible job to help demystify some of these complex things that we're talking about.
For sure.
And one of the things, what's that? Sorry.
Pictures are awesome,
Yeah,
and so
yeah.
my little girl loves the pictures, and she can explain the lipid clearance system in our bodies. So I figure we did something right there.
Yeah, for sure. So one of the things that we actually need to demystify further in our medical world and is Alzheimer's disease. There's so much confusion around what's going on, but clearly it's a massive problem in our country and the rest of the world. And you have a special interest in the cholesterol pathways and processes within the brain and how that might contribute to Alzheimer's disease. So can you tell us a little bit more about that?
Yeah, so if you think lipids below the brain are complicated, you start getting into cholesterol in the brain, and it is a whole nother frontier. And so the half-life of cholesterol in the brain is 6 months to 5 years, and it's kept separate from the rest of the body for a reason. 20 to 25% of your total body cholesterol is in the brain. And so it's crazy up there. And so we were talking about these ApoB particles below the brain. ApoB shouldn't be in the central nervous system to any appreciable degree. And if it is, it's causing problems. And it's not getting there as being transported from the periphery if it is there. But in general, the number one lipoprotein in the brain is going to be an ApoE containing HDL-like particle. So that's where people have heard of ApoE4 as a genetic risk factor for Alzheimer's disease. And if you have one copy of ApoE4, maybe a twofold risk of Alzheimer's. If you have two copies of ApoE4, then it's 8 to 12 times more likely that you might get Alzheimer's. However, it's not deterministic. It's one of those things where it shows you how much margin for error you have. But my take on this is, hey, if you never let fires start, you don't have to worry about a defective fire department. And after studying this a whole bunch, because this is where my PhD work focused on, I've narrowed it down to there are three big buckets of cholesterol disturbances specifically in the Alzheimer's brain. The first is defective cholesterol transport. The second is defective cholesterol elimination if there's excess. And then the third is decreased cholesterol synthesis. So keep those in mind. Those are three buckets there. And so what's supposed to happen in the normal brain is your astrocyte, that's a cell in your brain, it produces the cholesterol. And then the cholesterol is effluxed out into an ApoE, HDL-like particle. Well, the ApoE particle then delivers the cholesterol to the neuron. And cholesterol is really important for neuronal functions, for synaptic transmission, for the neuron to do what it's supposed to do. But cholesterol is really energetically expensive to make. The neuron's got other stuff to do. The neuron's like the physician or the CEO, the high-ranking executive who just needs his support staff to do their job so that he can, sign the prior authorizations if you're a physician, or, get the memo if you're an executive and take care of business. And everybody needs to do their part to ensure that the entire system functions properly. The problem with ApoE4 is that they're very easily distractible. So instead of acquiring the lipids and the cholesterol that they're supposed to, they kind of leave things strewn on desks. They start to journey over to the neuron and then get distracted. They get lost and they don't do the job. Well, when the neuron has to make its own cholesterol or make its own ApoE, that's a sign of a stressed neuron. And so that's not good. You're asking for burnout if the CEO is doing all the things that someone else on the staff should do. Additionally, when the ApoE particle is leaving cholesterol in places it shouldn't be, your inflammatory cells, the microglia, they get annoyed and then they mount an inflammatory response. And that's why we see toxic lipid droplets. And so that really kind of paints the picture of why we see decreased cholesterol transport, this cholesterol accumulating in places where it doesn't belong. And then, there's a negative feedback loop because there's these toxic oxysterols that accumulate, and then you have decreased total cholesterol synthesis in the brain. And so everything just goes wrong. And Alzheimer's is a terrible disease. I just recently lost my grandmother to that. There's a big difference between living and existing. And I think that if we can understand a little bit more about some of the characters in the brain that regulate cholesterol homeostasis, like PCSK9, like ApoA1, and there's something called ApoJ as well, ApoC1. There's things that I think are knowable that we need to know a little bit more about so that we can have an actionable, individualized, metabolic and lipid-centric cocktail for people who are starting to show those signs of early cognitive impairment. I believe it's possible. I 100% do. And so I think that that should give us some hopeful optimism. But in general, what's good for the heart's good for the brain, you know? And so focus on your home security system. Nobody ever said, I wish I was more insulin resistant. Nobody ever said, boy, you know, I think I'm going to start doing drugs now. That'll be good. No. So there are these axioms that we can always focus on, just because we really want to make sure that however long the good Lord keeps us around, we're making sure we're maximizing the life in those years.
Well, Josh, this has been fantastic. I mean, you're such a wealth of knowledge, and that's why one of the reasons I'm so excited that you're writing this book is that we can
There
get
it
it.
is.
There it is. So tell us more about, not only where we can get the book, but where we can follow you and get more from you, because, I've benefited so much over the years that we've known each other from knowing you and the stuff that you put out there and all the knowledge that I've gained from you. And um, I don't want to keep you to myself. I want everybody to have the benefits that I've had. So please, tell us where we can learn more about you and your book.
Yeah. So you can follow me on X, formerly known as Twitter, and it's at tag Josh J Wageman. It looks like Wageman. A lot of times I just tell people it's Wageman just because there's that E in there that's kind of throwing people for a loop. But you can follow me on there, and there's some real interesting discussions that happen with some of us lipid geeks on there. You can find me on LinkedIn. I'm on there, and I don't do a ton on there, but you can find me there. And pretty much you can find me anywhere that lipids are being discussed. If there's a cool, discussion about cholesterol homeostasis, I'm probably right around the corner. But really, if you just go to Amazon, right now, this is only set up for pre-order for ebook or Kindle, which is $9.99. I wish I could have set up the pre-order for paperback, but it was too much of a hassle. But on February 18th, let's say that you're so excited about this book. On February 18th, if you order the paperback, it'll be at your house within the next day or two, and it'll look like this. And so it is real, it is coming, and it is only a little over 3 weeks away. So hopefully you can wait that long, but I get it if the anticipation is just killing you.
Well, Josh, this is so great, man. I really appreciate you taking time to not only write the book, but talk to us today. And for everyone out there, it is the Home Security System and the Lipid Neighborhood, Uncomplicating Cholesterol and Cardiovascular Disease. Please go out and get it. To support my friend Josh, but also I really think it will help you lower your risk of dying from the number one reason why people die in the world. So please go out and do that for you and for your loved ones. So Josh, thank you so much for your time, man. Great to talk to you as always. I'm really excited for the book to come out, man.
Yeah, thanks so much for having me.